So thank you, Martin, for calling the meeting to order at 10:04. I appreciate it. Just that way we have it on the record. So my name's Dominic Zerlo, and I am the director for the medical cannabis program with the Department of Health. And I'll do a brief little presentation after the introductions. Libby, why don't you go?
Okay. Good morning, everybody. My name is Elizabeth Bessie, or Libby. I'm the health educator here with the medical cannabis program.
Okay. And Andrea?
Good morning, everybody. My name is Andrea Sundberg. I'm the health program manager, databases, and I'm the numbers dude.
And Gary?
Hi, I'm Dr. Gary French. I'm the medical director here at the medical cannabis program. Thank you.
Okay, and just so that you do know, we do have two other of our staff that are in the attendee list, and that's Brenda Martinez and Kathy O'Gary. We also, who both are with medical cannabis program, and then Haley Peterson, who is with the epidemiology and response division. And back to you, Martin.
Fantastic. Next on our agenda is to, I think it's kicking it right back over to you, Dominic, to talk about program updates.
Committee members.
Oh, I'm sorry. Update from the medical cannabis program is next on my agenda. Oh, the next people for introductions. My bad.
That's
Sorry,
okay.
trying to do two meetings this morning and missing a few of them. So let's go ahead and start with who is next in my layout view. There we go. Dr. Faust, would you like to go next?
So I've been in Santa Fe about 17 years, retired from venture capital, but and have been teaching epidemiology really my whole career. Started at University of Michigan, where I was on the epidemiology faculty and family medicine, and then ran HMOs, staff model type HMOs for a number of years, then moved on to venture capital, where I helped to found about 25 companies and get them financed, sometimes chair their boards and that kind of thing. And in my 50s, I went back and got a philosophy degree and became a bioethicist. I did a bioethics fellowship at the University of Toronto's Joint Center for Bioethics. And so I'm, I guess, a peripatetic type of doc.
Thank you, sir. Moving next across my grid, I have Dr. Plymouth.
Hi, Alan Plymouth, a resident of Deming. Grew up in Raton. And I'm now 2 days a week at a medical clinic here. So I have a lot of time to spare, and that's why I'm volunteered to be on this committee and looking forward to it.
Thank you very much, sir. Dr. Barrett, how about you? Would you like to go next?
Hi, good morning. I'm Eileen Barrett, and I'm a general internist. I am in Albuquerque. During my, I also have done some research on the care of people with substance use disorders, and also am published in those areas as well as in health equity. And somewhat related to this is that I am in the inaugural group of fellows through a collaboration in medical justice and advocacy through the American Medical Association, and also Morehouse School of Medicine, which is an historically Black college and university. And great to be here with all of you, and thank you. And I think I'm co-chair. No, vice chair, not co, vice. You are El Capitan. I am vice.
Thank you very much. Next on my grid, Katie, would you like to go ahead and introduce yourself?
Yeah, sure. Hello, I'm Dr. Katie Wikowitz. I'm a professor at UNM as well. I live in the East Mountains and a licensed clinical psychologist, and have done about 20 years of research on substance use disorder treatment and harm reduction based approaches to treatment in particular. More recent interests include recovery, and I've also done a lot of work in developing mindfulness-based interventions for substance use disorders and mental health. It's great to be here.
Thank you, welcome. And I think Ryan, last but not least, on my grid.
Sure, Ryan Nix. I'm Executive Director of Alliance of New Mexico. We're a nonprofit helping people living with HIV, people who are interacting with our harm reduction program for syringe exchange and naloxone, I've done HIV work my entire life, actually published some documents with the Center for Sexual Health Promotion concerning bisexuality. And this has been my entire life doing HIV work and helping those a little less fortunate. So I've been stuck in the nonprofit world.
As am I know that situation fairly well. Thank you. So yeah, I think that is just about everyone. Dominic, next would be the update from the medical cannabis program. Oh, did we introduce other guests? I see that there are some other guests that aren't listed as panelists. Anybody else, would they like to introduce themselves?
And Martin, those are the 3 individuals that I announced earlier that are all with DOH.
Okay, fantastic. Thank you.
Okay.
We have Mateo too.
Mateo just joined.
Yep.
Mateo, would you like to go ahead and give yourself an introduction, please, sir?
I apologize. I had a hard time getting in. And I didn't hear any of the introduction, so I don't know what to go off of here. But I'm Mateo. I'm a researcher at University of Mexico Center on Alcohol, Substance Use, and Addictions, and do a good amount of work in cannabis and the more on the risk side, but growingly on the medicinal side.
Thank you very much. Dominic, now would you like to go ahead, please, with the program update?
Absolutely. And I'm going to go ahead and share my screen here in just a moment. Let me get this. Okay. So can everybody see the title page for the medical cannabis program? Okay, perfect. So just as usual, anytime we do any presentations with Department of Health, we want to make the acknowledgement about, on behalf of the Department of Health and all of our colleagues, about the fact that we are on unceded ancestral lands of the original peoples of the Apache, Navajo, and Pueblo, past and present. And with gratitude, we pay our respects to the land, the people, and the communities that have continued to contribute to what is known as the state of New Mexico. This is something that, if you're not aware of it, we have been really trying to ensure that these acknowledgements are happening whenever we start talking about community or talking in community meetings, because we believe that the diversity and recognizing the history in the past and how it affects the present is so important in all areas here in New Mexico. And then what I just wanted to do is I wanted to show you all just a couple of graphs of what our patient enrollment looks like. And these are just some simple items. We're actually working on getting some better analytics and graphical programs so that we can actually have things look a little bit better when we present them. But that hasn't quite happened just yet. So in the meantime, I just wanted to show you a little bit about the trend for the program. And so this particular graph goes from January of 2021 till this past January of 2022. And as you can see, our rate of enrollment in the program, while it slowed slightly during the winter months, which by the way is very usual, we have fewer applications come in during the winter and the holidays than we do at other times of the year. We still are showing from January to January an increase of 23,000 enrollees. On average, the past 2 years, we've seen 26,000 individuals enroll each year for the last 2 years, and that trend has been continuing. And again, the slight slowdown due to the normal winter month slowdown, but we anticipate that to increase quite a bit coming up, especially with recreational sales starting in April. And then this slide is showing our enrollment by qualified conditions. And this is showing based on alphabetical order of the condition. It is one of the slides that we kind of do because people always ask on a regular basis, when they look at the larger or the other slide that I'll show in a moment, they sometimes say, I can't find the condition that I'm trying to find because there are so many different conditions. And so we do this one just so people can find it easier from an alphabetical standpoint. But from a data standpoint, this slide seems to be a little bit more used, where we actually show the enrollment by conditions sorted by the number of people enrolled for each condition. And as you can see, our number one condition for enrollment remains post-traumatic stress disorder. And then with a little more than half of the people who are enrolled for post-traumatic stress are severe chronic pain. And as I mentioned earlier, we have 130,000 people in the program. And if you actually add this on up, you'll notice that that is most of the people in the program, just even in those two conditions. And then the rest really is a little bit more than, I think it ends up being about 12 to 13,000 people who are enrolled in all the other conditions combined. And then these are just the top 5 conditions. Again, post-traumatic stress disorder, severe chronic pain, cancer, painful peripheral neuropathy, and autoinflammatory, autoimmune. Oop, I have a misspelling, my apologies. Autoimmune mediated arthritis. And so the thing that I find to be really interesting about this from a statistical standpoint is we really come from post-traumatic stress disorder with 71,000 people to just the third, the third most enrolled condition being cancer at less than 10% of that. And it really is showing what the driving force behind enrollments are, really being that PTSD and severe chronic pain.
Dominic, do we know anything about the PTSD enrollments? What the cause for the what the traumas were, if you will?
That's a great question, Haley. And the thing that the short answer is no, we do not. And it is one of the things that we would like to know a little bit more about. However, our current enrollment process, we can't really collect a lot of that type of data. And we do have a survey that is going to be going on, but it's a little bit more about other aspects of the program. But this is one of the data collection points and something that we would like to see about doing for future surveys to find out what are potentially are the reasons, not just a broad category of PTSD or severe chronic pain, but what type, what is actually happening on that. So that's a great question.
When you say we can't collect it, does that mean by statute we're limited, or we just haven't done it so far because of resource limitations?
It comes down more to resource limitations, and anything that we collect, we have to publish. And a lot of times patients are not necessarily, for a registration in a program, they don't necessarily want to provide that additional information, just the category that they're in. So when we have done some of those in the past as part of the registration process, there's been pushback because we did try to do that, especially in the early years of the program. Now, that doesn't necessarily mean that that's not something we couldn't potentially see about doing. Or even doing some review of charts in order to be able to find some of that information. But that hasn't happened due to resource.
Okay, thank you.
Not a problem. Thank you for the clarifying question. Oh, somebody else?
Dominic, this is Eileen. Thank you for presenting this data and for the answer to that last question. And I have a question that's a little bit similar, which is, do we have data that suggests what was tried prior to cannabis? Because as I understand, it's quite controversial whether cannabis can make PTSD worse, and that the APA has a statement against the use of medical cannabis. And I don't know if they're in the process of revising it. Their last statement on it wasn't that long ago. Do we know if this was maybe like, oh, one had tried multiple things and really nothing else was working? Or do we know that? And is that something we're able to get?
So we do not know that. But again, that would be the kind of thing that we could do in some of the surveys of patients that we would look forward to doing. We currently, he attended our last meeting, but we have contracted with an organization. Let's see if I can remember the initials, what the initials stand for. Everybody always laughs. I get used to saying CPPC. And it's a cannabis public policy consultants. And thank you, Andrea, for nodding your head and making sure that I was correct in that. And they are actually individuals that we have contracted with to do surveys. We do have them initiating a survey right now that includes focus groups of patients. But for future surveys, we could add in exactly these types of questions that you're asking about. And that's actually part of the type of research we really would like to see about doing. We also have other individuals here that are on the committee who may potentially be able to help with some of that as well. And I see Katie nodding your head. And by the way, Katie, just as an aside, great presentation yesterday. So.
Thank you so much, Dominic. Glad you could attend. That's great. And yes,
Ryan?
we're I think Mateo and I are very eager to help in any way, kind of dig deeper on some of these questions.
And just to note, this is why we're presenting this data, because these are the kinds of questions from all of you that we want to get so that we can look at what that future research should look like. That makes sense. And Ryan, I'm sorry, go ahead.
But for clarifying, really, this is about the medical cannabis program that you're presenting right now, but this isn't really work that we as a committee will do, right? Because we're not really, there's already a committee set up for the medical cannabis program. And really, we're supposed to be looking at recreational. From what I understood, that there already is a committee for medical cannabis, and we're supposed to be looking at effects and everything for the new law that has gone into effect. Is that right? Just so I'm clear.
Sure. So that's a great question, Ryan. It's actually about all cannabis use, both medical and recreational. So the medical advisory board itself has actually very specific job duties that they handle. And so this one really is the committee with regard to research about cannabis in general, both medical and recreational. And so some of these questions actually, may apply, and not necessarily the specific ones that have come up so far, but may apply across both areas, and some may only apply in one or the other. So that's a great question.
Great. Thank you.
Essentially, if it's about cannabis research, this is the committee. And then the one other slide that I just wanted to show, and I presented this last time, and it's just, we didn't update the data on this yet because just quite frankly, going through to update each county, we're getting a new map system, but this one takes a little bit of time to do. And the data hasn't changed that much since then, since the end of September. And so you can see that we do have medical cannabis patients in every county throughout New Mexico. And so this is really a broadly utilized program. But you will notice, of course, that the rural and frontier counties are the ones that tend to have the least enrollment in them. And so some of the questions that come up on that, of course, is it a question about access or is it a question about need? And so those are some of the things that actually in the current survey that we're deploying that cover some of those issues, if that helps. And I just wanted to show this map because it's got pretty colors, quite frankly. So, but in any case, that's really all we wanted to show as far as data. We will give you the updates about the data on a regular basis, just so that as it sparks questions and concerns or ideas, we want to be able to have that. And as we continue to delve more deeply into other things such as sales and especially as recreational starts, we'll start to have some more ideas of how much people are purchasing. And so with that, I actually do have an announcement, and that is not a part of the presentation, but I think that that some of you at least will appreciate, is we have been in the process of a rulemaking process for the last several months. And today our new rules were promulgated, and that does include an increase in the adequate supply limit to 425 units, which is approximately 15 ounces for patients and reciprocal participants. Previously, the limit was 8 ounces, which equates to 230 units approximately. And patients could turn around and they could apply for a unit increase going up to 12 ounces or approximately 345 units. That now is not something that they need to do because with the new limit, there's no need for the unit increase letters. So it helps streamline the program for patients and reduce some of that, some of the paperwork on that side. One of the other things that did also happen is the Cannabis Regulation Act also decriminalized or changed some of the ideas behind what constitutes a crime with regard to cannabis possession. One of the other things we had in the program that had been in place since the beginning of the program was caregivers had to do a background check, but it was for exactly those items which now the Cannabis Regulation Act has gotten rid of as far as disqualifying conditions. And so our regulations also now match that, and background checks are no longer required for caregivers for patients. And so those all went into effect this morning, and we're in the process of updating the website. That usually does take a couple of days. We unfortunately can't update it until the rules become promulgated. So it'll be over the next few days that that information is posting up to the website. Oh, did someone have a question?
Yeah, Dominic, just real quickly, I'm not familiar with where the populations are on the peripheral counties that you mentioned in your last slide. And I'm wondering if in the future you might be able to put, in essence, what are prevalence rates on here so it would give us an idea, because if the rates are similar to where the more populous counties are, then it may not be an access issue, it may be something else. So.
Right, absolutely, we can do that. That's part of what we're working on with some of our upgrades to some of our other programs as well, or our IT application programs.
Thank you.
Okay, and then Dr. French, Gary, did you have a little bit as far as updates?
Yeah, I had the opportunity to talk to Andre and get a couple of numbers for us here. This is in regards to electronic application, which is something that we instituted this previous year. And this was done to help patients access the program, also access more information. They can see what they purchase. It also helps providers continue discourse with the patients as well, because they can do visits via telemedicine and then do the annual verifications, the follow-up visits also by telemedicine. And so this has really helped out our New Mexican patients because they've had greater access to their providers. So currently we have approximately 70 providers that are registered and utilizing the on-patient portal to do medical applications. And I'm glad that these are a lot of our more prolific providers as well. So approximately 300 applications a week are done electronically. And when you compare that to the ones that are coming in via paper, that's about 30%. And we are continuing to see a gradual increase in providers register, as well as the number of applications that get done. And also what's exciting is the caregiver applications. We're starting to see those also uptick as well as information change forms. So these other forms that we do have are also being done electronically. So yeah, very similar to the graphs we saw earlier, a gradual increase in these numbers. Thank you.
And then Martin, Libby does have a little bit of an update about what we've been doing. It also fits in as far as part of the beginning of the discussion of research and resources.
Wow, fantastic. Great segue. Libby, go ahead.
Yes.
Thank you. So as Dominic mentioned, a large and the biggest part of what you all will need to be working on is providing to the legislature and to us is an annual report on the health effects of legalizing cannabis products for adult use beginning December 1st, 2024. And part of that, we are trying to assist you in a platform to help you share articles. And Gary, Dominic, and I have been working on vetting some articles related to the elements that need to be in this report. So child access, road safety, workplace safety, consumer and product safety. We've been looking at various articles that we thought, were useful and maybe helpful in your report, just so that, you don't have to read through a bunch of maybe not so great articles. So we have found let me get this shared. A platform online. Wait,
And just to let those of you at UNM may be very familiar with this platform.
Okay, let me see. It is taking me a minute. Okay, here we go. Now that I'm the presenter. All right, here we go. So our project manager is very well versed in IT and just kind of helping us find solutions for some of the more technical applications that we need assistance with. So thank you, Kathy. So we could use this platform to help organize the articles that we find and you all find. This is a private group that we can be part of and share these articles. So are you able to see this? Cool. Okay. So on the left-hand side are all the various topics and elements that will go into this report. And underneath those, some of them we have articles for, some of them we don't yet. So under child and infant safety, we've added this article here. It tells us the main author and the date of publishing. So we've added that. You're able to add notes along with it. It gives you a little bit of info here on the right-hand side. You can add some notes, any tags or any relevant attachments. So that's really helpful. You can drag and drop a PDF into this file and it'll populate all the information. You can also use this fancy magic wand and enter a URL or a DOI to help populate that article as well. So right now we're kind of in the infant stages of this application. We just learned about it this week. Kathy and I worked on it. So we thought this might be a helpful way for you all to share and communicate and check if any of the articles are viable. So that's kind of what we've been working on, and just wanted to get some input from all of you to see if it was a worthwhile application for your research.
Sure. So this looks very much like EndNote in many ways. Is this something you download to your computer and then use, or is it something you go online to use through UNM, or how?
So thankfully, it's fairly easy. You can just work from like a web browser. I didn't have to download anything onto my computer, which is helpful. Since we probably don't want to clog our computers too much with everything that we have going on. So this is just from my web browser, which is nice. And so you're able to just access, log in and get working.
So you'll send us the link then, and
yeah. Yes. Yep. You'll get an invitation to join the group, and then you'll be able to see all of this and add your own articles and notes, and then you all can discuss them and see if they'll contribute to your report.
I'm wondering also, I would guess that the other states that have been in this longer would have would have sorted through a lot of this information as well. I mean, is there any communication that you have with Colorado or state of Washington or whoever else it might be that's had to do the same kinds of things we're doing now, and maybe they can give us some sort of the 5-star articles that we ought to be looking at initially?
Yes, definitely. We haven't started that yet, but I do know that that's something that we would like to assist you all with.
And just to note, we do communicate with many of the other states on a regular basis, and we all share articles and things like that. Some of the articles that are actually in here are actually from some of those other states. So we haven't done it in a formal fashion. Oftentimes it's been, either like Libby or Andrea or I reaching out to someone we know and say, we're looking for, information regarding this particular topic. have you done any research, and then getting it from there. So.
I'll just add,
Can
oh,
can
sorry.
you star them, like on EndNote, you can put stars on or give priorities to articles of more importance.
I don't know that yet. Like I said, we just kind of discovered this and got into it earlier this week or late last week, I guess today is Tuesday. So hopefully, we'll learn a little bit more about it and see if that is a capability.
Sure, that'd be great.
I'll just add, I've used Zotero a few times. It works similarly to EndNote. There is a downloadable version if you like something that lives locally on your computer. But one of the main benefits of this is that it's free. So all of us should be able to access it. And it works pretty well. I'm not sure about the favoriting, but you can, I think, put notes. Like if Libby, if you click on one of these articles, there should be a place right there on the right there to put some notes if you wanted to do so. And so you could do that. And I believe you could also tag them, and potentially we could create a word that tagged favorites. And then you could add a tag to it that would be a favorite kind of one word that we use to indicate a one we want to come back to.
Oh, that's helpful. Thank you for that, Katie.
Yeah.
Other folks have anything to add? Is there any other question or discussion?
This is Eileen. I'm so grateful that we're looking for a science and literature and expert consensus advisory role that we end up getting. I would ask us if we could do two things. One of them is that if we recognize that the landscape is changing really quickly with the rapid expansion of decriminalization, and but actually not even just decriminalization. Let's throw that out because that absolutely needs to happen. But also now with more expanded use than we've seen, and more research, but that we have a very narrow look back in time, so that we prioritize studies that are within 3 years and consider none more than 5. Because things have changed so much. So I'll ask us to consider that. I want to hear what other people's thoughts are. The other thing that I would ask us to do is, and I think it's so meaningful to have a repository. I think that one of the things I would recommend that we consider doing is also recognizing that there's a lot of expertise on this call. There's also a lot of expertise at other institutions that we may not have access to. And when I think about people who are really committed to harm reduction and also have the resources to be able to do comprehensive reviews, I do think about the American Society of Addiction Medicine and also the American Public Health Association. So I think anywhere that we can prioritize any policy or recommendation statements that they have, I would recommend that we have those featured more prominently, possibly even in lieu of individual papers, because what we saw with COVID, of course, is that people chose like one paper in ivermectin, and then that is constantly being repeated, even though the overarching consensus of everybody who is an expert in COVID is that ivermectin doesn't work. Same thing with hydroxychloroquine. So I think that what it showed us is that we put too much burden on people to interpret the body of the literature, and that is okay to, and that it is recommended at times to just acknowledge the expertise of people who do this inside and out, and have the command of the full body of literature. So, I mean, those are the two societies that I would think of the most would be APHA, ASAM, and then I know less because I'm not a pediatrician, but I would wonder about the American Academy of Pediatrics.
Ivermectin doesn't work? Oh, I'm sorry.
It does work.
Roswell, there's all kinds of people that are like physicians prescribing it. So it's, I know someone who had that and said, hey, do you want to be on my husband's regimen? So yeah, that is real in southern New Mexico for sure.
Sorry.
Ivermectin works for the purpose which it is normally prescribed, but not necessarily the purpose for which it's been utilized in the last year and a half.
It's also approved for rosacea by the FDA, just in case, for those who didn't know, just to let you know.
And back to what Eileen was asking though, is that is a part of what we're looking at, but the other side of that, and I say this as the caveat, it's part of why we wanted to get a communal location to put items, because you all do have that expertise. It's part of why you're a part of this committee. And so it will also fall upon each of you to also seek out some of those connections that you have or the information you already have. I know many of you already have a library worth of of articles and research regarding this, and to be able to share that through this. So those are great suggestions, and from the program standpoint, we'll continue to add to that and see what we can do as far as additional areas. Drug Policy Alliance, for example, has quite a few articles that we've been borrowing, and several other locations as well.
Ryan, I saw your hand up.
Yeah, I would really be interested, Dominic, since you guys have some connections in other states such as Colorado. I kind of mentioned this last time, but I know through this process, a lot of individuals who are against or might not, for example, in Roswell, we have numerous city council people who constantly kind of like go back to their report, that Eileen was just mentioning. See, look, Colorado says this is horrible. And so how do we put out a product that is, someone will just hone in on that and they will repeat something 700 times. I would be really interested to hear from states who have produced documents. Do they have any regrets of our areas of we wish we would have presented this in a different way, or we wish we would have, I'd rather know that going up front as we're moving forward and thinking about, okay, we have to produce this document. What are lessons learned from other places so things aren't cherry picked out, or are there anything that other states could provide us with guidance? I would be very interested in that from other groups such as ours that have done this in the past.
Thank you, Ryan. So what I'm hearing is you would like us to see if we can help arrange to have some of those individuals potentially join the conversation here at times.
Potentially, or are there any, do they have, I know they produced, Colorado's report. I mean, somebody was lifting it up in a city council meeting saying, see, Colorado says this was a horrible decision that they have, and I'm like, that's not fair. And I know that report doesn't say those things, you know what I mean? But yet you're reading the sentence over and over and over. And I just don't want work that I'm a part of to, if there's something I can do preventatively, I would much rather do those things, or kind of have some guidance that would be helpful.
Absolutely, we can help work on that.
I think it's a really good point. I mean, how we've had this problem with the communication of science certainly throughout COVID, and forgetting political reasons, even more recently from the CDC, making substantive changes and then, but not being fully explanatory. And there is a whole science of the communication of science, if you will. So it's an excellent point, I think.
Everyone isn't lucky enough to live up north.
Okay, is there any other discussion or any other comments?
So Martin, just there has actually been a request from Haley Peterson, who is joining, in the participant, where who is from our ERD Epidemiology and Response Division, and they do have quite a few resources as far as databases, things like that, to do a presentation at the next meeting. Is that to talk a little bit more about those resources and to sort of show some of the data that has been collected already through epidemiology here at DOH. Is that something the committee would like to have happen?
I'm seeing lots of thumbs up and head nods. Anyone like to have more discussion around it, or does it just sound good to everyone? Let's move forward.
And Martin, if it's okay, Haley is here. Can we unmute Haley? Haley, would you like to say anything? This is Haley Peterson.
Hi, can you all hear me?
Yes.
Yeah.
Great. Yeah, hi everyone. So I'm with the substance use epidemiology section here in the epidemiology and response division. So I've been working on cannabis as sort of a side project for myself for the last few years. I'm part of the Council of State and Territorial Epidemiologists Cannabis Subcommittee. I've attended several meetings on cannabis public health surveillance and worked with that committee as they sort of start to develop standards for how we're going to monitor cannabis and public health. So I would be more than happy to give a presentation on sort of what we've, sort of the national landscape that is often talked about among committee members, and then some of the local areas of data that we have available at this time. So I'd be more than happy to do that at the next meeting.
Fantastic. Thank you so much. Does anyone have any other questions for? No, and it seems like it's a fairly unanimous effort to approve that, to ask for that, please.
Great, thank you all.
Fantastic. Thank you very much. Okay, shall we move on to our next agenda item, or is there any further comment? Or were there any further suggested action items? Okay, moving on to the next agenda item. It's are there any other items from committee members? Is there anything else on committee members' minds that we'd like to speak about this morning?
Was there anything in the current legislative session that would impact what we're doing, either through questions raised by legislators or resource changes, positive or negative?
Great question.
So I'll go ahead and answer. As far as the cannabis, there was Senate Bill 100, which did not make it through the final Judiciary Committee, and so it did not make it to the floor. That would have had a few changes with regard to the Cannabis Regulation Act, but did not make it through. There may be some things with regard to the expansion on the Harm Reduction Act that may eventually affect individuals who are involved in the harm reduction programs who may also use cannabis. And what that act did, the amendment to that act expanded the ability for the department to be able to, distribute items that help with the reduction of substance use, with harmful negative effects from substance use, as well as reducing infectious disease transmission. So some of that may end up affecting patients with regard to medical cannabis or recreational users. But at this point in time, none of that has, they're starting to implement that now. I guess we're waiting for the governor's signature. The plans are being done for implementing that particular statute. Other than that, nothing else really that directly affects the program at this point in time.
Thank you.
Thank you, Dominic. Other questions or other topics of discussion? Dr. Barrett.
Thank you. This is very tactically, and this is something that I'm embarrassed that I don't know the answer to, which is that thinking about how exciting it is, the issue of having the fentanyl test strips, which is that thinking also of adulterants and clinician education and prescriber or certifiers education and users education about potential adulterants in cannabis. Is there, I should know this, but about the safety of the supply that can be provided to the patients in the medical program, but also to in the recreational program. This is something I should know, and I can't believe I didn't think of it till now. I'm so sorry.
That's okay, Eileen. So part of that actually, there is within the Cannabis Regulation Act and previously under the Lynn and Aaron Compassionate Use Act, the ability for product that is being sold through dispensaries to be tested. And they are actually working on those regulations still on the cannabis side, I believe they actually have some that are actually proposed at the moment. I can't quite remember, to be honest, so many different regulations happening all at the same time. But they have been working on those, and we previously had a variety of different testing requirements for medical cannabis as it was. I can say that our last set of rules that actually greatly expanded the testing for adulterants and contaminants was actually ended up being challenged in court, and due to a technicality was actually overturned. And so we had rolled back to the previous testing. And the main reason for that is, well, again, it just going through the legal machinations. But the current Cannabis Control Division is looking at implementing many of the similar testing requirements, as well as some additional testing requirements, looking at things like pesticides, other potential contaminants, mold, things like that, to be able to ensure that there is indeed a safe supply for all individuals, regardless of the reasons for using.
Thank you so much. In addition to for the things that you mentioned, does it also include for other adulterants such as spice, methamphetamines, fentanyl?
So
or is that considered not necessary? I should ask. Just my experience from talking with patients who, when we have conversations about someone else ordered a tox screen, and I just want to understand what to treat them for, right, and what treatment to offer, and some people are really surprised. And
so I don't believe that that is a part of what they are doing as far as through dispensaries. The issue really would come in, and where those would become a bigger potential issue or problem would be if it is being purchased outside of the legal system. And that would be where the main concerns come in. And so that may be part of why, if somebody is reporting that they are getting cannabis from other locations, other than through the dispensaries, that may be why they may be ordering those additional tox screens. But that's a great question and a great thing to consider. And I should mention that may be part of why down the road in the future, there may be the expansion of the Harm Reduction Act may have a very real impact as far as cannabis use, especially here in New Mexico. The technology also has to develop for it. That's the other side. What I can say is when the medical cannabis program first started, we didn't have any ability to test anything, quite frankly, because the testing, the technology wasn't even there. There weren't even tests available to determine THC concentration. And I mean, there were some that you could do in a lab, but they were well out of any price range that would have been reasonable. And to be able to get an accurate reading, you would essentially have to take all of a crop and a harvest, homogenize it in some way, and then send it in for testing. Testing itself has actually progressed quite a bit over the last 14 to 15 years. And so now we're able to test for other items as well. So it's a constantly evolving and changing landscape.
Wow, thank you. Anything else from other committee members, other items? Yes, go right ahead.
I feel like I should go last. I was going to ask, we just heard when we saw your report, the report about in the medical use, and I was wondering if when we're thinking differently about how we can present data, if we will be able to present data on gender, race, and ethnicity in the reports, with the reason being that it is, of course, so well documented about the mental health crisis that is occurring. And I think that it might be able to help us identify areas to prioritize for provider professional development, right? As well as any other future, particularly when I see PTSD, that is leading, because I would have expected would have been cancer would have been leading. But it might help us provide some targeted provider education and maybe patient support and community support. I was also going to ask about and this may be that you already have it already, but if we have guidance for managing, for employers about managing positive drug tests in the workplace. I think of that because that specifically came up in my hospital about how it could affect medical students and how it could affect physicians also too. And then this is just a few because then I'll just stop. And then I suspect you're already tracking it, but the effect on the medical program of having the expanded legal access for recreational use, and just what are the different implications and complications of that. I don't know if any of it has to do with also how that could affect economics. It's been interesting over time to read different articles about what were the cash influx in the state related to legalization. While we track all the other reasons that we really want to do it is for decriminalization and to try to de-racialize the criminal justice system. And then the other thing was that if we have reports on the prescribers, I know that people know that with the opioid use disorder epidemic and what stemmed also from a lot of providers inappropriately prescribing opioids. However, there was a small number of people whose prescribing patterns were so aberrant. And so what could be the role of tracking who are the people who are making these referrals and recommendations? And who are not, right? Because that also gets to the area of, I think it was maybe Haley who had previously said unmet need. That's a lot at once. I'll stop there.
Yeah, but those are great questions. And I will try to answer them in the order that you requested. So we do collect demographics, but it is an optional aspect of it for the collection for the program. And we can definitely report that on out to you and to the committee. Again, that's a part of some of the reporting that we're working on improving and trying to expand so that we can actually have some better data to be able to share. As far as employers, it really is up to the employers with regard to the legal aspects. We can't actually give legal advice. We can point to the regulations and to the statute. As far as for employers and what they do, the statute is pretty clear as far as it is not an illegal item or a legal thing to do, so long as the individual is not doing it at work, and if they are not in what is considered a safety sensitive position. So for example, the safety sensitive position could be something like somebody who's operating heavy machinery, things like that. But other than that, we as Department of Health can't actually give legal advice to other employers. So they do have to seek that out. And then let's see, the next one was about as adult use sales start, how that actually complicates potentially the medical side as well as the economic aspects. And we can look at some of the things that have happened in different states to sort of have a bit of an idea. But because every state has a little bit of a different system, and some have medical programs, some do not, or depending on how their medical programs are set up, the results are sometimes very different. And so I think we're going to have to wait and see a little bit to see what happens. We do anticipate our enrollments in the program will start to increase, in part due to the tax benefit, or I should say the lack of having to pay tax on cannabis if someone is a medical patient, up to the adequate supply. And it is a part of the reason for the increase in the adequate supply limit that I mentioned earlier that went into effect today. So that's a part of that. I'm not sure if I answered that question fully. I think there's a lot of aspects of it, and a lot of them are we kind of have to wait and see a little bit, unfortunately. But then the last one about prescriber impact, that is actually a very big topic. And this committee is not the only one that's actually discussing it. There's been discussions in the Overdose Prevention and Pain Management Council as well, and side conversations occurring with regard to how will cannabis, especially when it is commercially available, how will that actually impact potential prescribing behavior? And will people be self-medicating? Will that be a positive or negative item? How much will people be speaking with their providers about how much cannabis they're using and what types of cannabis? So there's a lot of questions regarding that. Now I can say anecdotally, which anecdotally does not necessarily equate to data, as Secretary Grace is fond of saying. But from an anecdotal standpoint, we've had many patients relay to us that they have been able to reduce the amount of opioids as well as other medications that they're taking after joining and being a part of the program for a while. So, but that is an area of research. That's an area that we need more information, and not just from patients, but also from the medical providers. And that is an area that we definitely need to expand and see what is happening with prescribing behavior. For example, the prescription monitoring program will tell us about reduction in opioids being prescribed, but it doesn't tell us if it's being supplanted with a different type. So is cannabis being used as a type of medicated assisted treatment, for example, or is it even being utilized at all? So there's a lot more research, and we definitely, at least from a program standpoint, would like to know more as well. So I think I got all your questions. Are there any I missed? And I don't know that I answered any satisfactorily.
I think that you answered all of them satisfactorily, and I think that that there very rarely is a yes/no answer to something, right? Because it's complicated and the landscape is changing, and I'm just really grateful. I think that one of them, and I may have, because I was like sort of taking notes on my laptop, was I think that you said this was that provider education, and I think you said that and I missed it.
So a lot, well, there's different aspects of it. And I know Gary had mentioned provider education, and he actually does a fair bit of that. So Gary, would you like to talk a little bit more about what types of education you're doing currently with providers?
Sure. And I think, Eileen, you had mentioned tracking of providers, and also tracking those providers that don't necessarily certify patients for the program. So yeah, that is something that I do. When applications come in, there definitely are varying degrees of professionalism with regards to certifying providers. And for those that sometimes do lack information and do need help with regards to creating a better document or a better note with regards to certifying patients, I do outreach to those providers and try to guide them. Now, PTSD is actually one of the items that in a recent presentation, we tried to bolster that, or at least create some criteria to help providers certify PTSD with a better knowledge base, and to do it, to really check the boxes, really do the evaluation so that we're getting good PTSD diagnoses. So again, it runs the gambit. The cancer patients, it's pretty obvious, this patient has this qualifying condition, they meet the criteria. But then the question is, well, what do I dose the patients with? So, things we reach out to are elderly patients. How do we dose an elderly patient as regards to a younger patient? What types of modalities or treatment options are going to be best? Smoking versus aerosolized versus tinctures versus edibles. What is going to work best for which diagnosis, which condition? And actually, with our questionnaire that we're going to be doing, we're going to be asking the patients that question as well, because cannabis is so often, it's a self-medication, self-titration. So they know what works best for their conditions. And I'm really anxious to see what substance or what products seem to work best for what conditions. But yeah, there's some very generalized, approaches to it. But really, it's trying to help the provider address the patient's age, what their condition is, and give them some suggestions. And then also some suggestions on concentration as well. What type of concentrations work best for certain types of patients. And then really start low and go slow. If the patient doesn't even feel effects the first couple of times, that's an okay thing. And again, so much of this is based on the follow-up. encouraging providers to provide follow-up to the patients they certify really is a linchpin as well. You know, the primary care providers that certify their patients, it's more easy with them. But some of our other providers, again, might not see the patients as frequently as one would hope, and therefore aren't following the benefits that patients are having, or perhaps the problems that they're having. And then I think you mentioned tracking providers as well. You know, one group of providers are the federally employed providers. They still have reticence to really certify patients for the program. You know, I think when this goes with the advent of recreational sales beginning, and the acceptance of that, you know, cannabis is now, it's legal. We should ask the question, who's utilizing it? Just like we ask who's smoking or who's using alcohol. It needs to become a question that's asked every visit. I think that we're going to see some of the stigma go away with our state providers, and hopefully we'll have more providers certify patients, and we'll get it back into the realm of the primary care provider. The other watershed will be when the federal government, you know, when they pull back, when they start advocating for cannabis use, and federal laws, you know, are more in tow with state laws. I think that we will see a huge number of providers then enter the market and really dive into cannabis and its medical uses. So hopefully I answered your question as well satisfactorily also. So
thank you very much, Dr. French. Okay, any further items from committee members? I had one thought occur to me as we have all sent in bios. Well, almost all of us have. I still haven't gotten mine submitted yet, but it's on the way. I'm submitting bios for the program to be able to talk about who is on the committee. How do we feel about headshots to include with those bios? Headshots as part of the bio. Some heads nodding.
Yeah, it's fine with me.
Is there anyone who would be against that, or who would want to send in a no image included photo with a bag, brown paper sack? Okay, I'm not hearing anything. So if you're able, please submit a headshot to the program, to Dr. Branch, Dominic, so they can include that with the bios. That would be really helpful. I don't think anyone is going to judge based on how old or recent that headshot is, so take your pick. Anything else from committee members? Or from program staff as well, I guess. Anything else from anyone? Because we're moving on to our last item. Go ahead, Dominic.
I was just going to say, I can't think of anything in particular. The one other thing, I'm sorry, I do actually have one other thing. And that's, we are still, of course, looking for additional members for the committee. And we do have some, some inquiries out, especially with regard to child safety. That is one of the big areas. And pardon me. And the other one with regard to law enforcement and road safety. We have some inquiries with regard to that, and are looking for additional committee members on there. So if anybody happens to know anybody as well, if you want to forward their name and contact info to myself or Gary, Dr. French, then we will follow up from there.
Thank you, Dominic. Well, it looks then like we might be ending a little bit early today, if we can figure out how we might be able to schedule our next meeting.
Was the
Seems
doodle
like-
poll a helpful tool for all of you to, excuse me, to help decide when that meeting time would be? We can come up with a few times, Gary and I, again, and send that out to help you all find a time that works best for the most amount of people.
I think that it works best, Libby, if we're able to at least narrow it down to like these 2 weeks in this month, so that it'll make it much easier for you all creating options to kind of come up with.
Absolutely.
So when would the next month be that we would need to have a meeting, at least quarterly, or?
Actually, Martin, that is up to the committee to make a decision on how often or frequently you want to meet.
Wow, such
Yeah.
power.
Now, just as an idea, you know, we essentially looked at about 2 months in between, not quite, but about 2 months between for these meetings. So that might be something to consider. But it really is up to all of you.
So something in late April or early May, would that be something that might be doable for everyone? Seeing lots of head shaking thumbs up. Anybody that would absolutely not work for? So there's a few weeks, maybe a program can look at those weeks to find some options for us and create a doodle poll. That would be really helpful.
Does this Tuesday timeframe work, this 10 to 11:30 on a Tuesday? Is that sort of a sweet spot for people? And should we focus on Tuesdays?
Usually can make decisions far out as long as I have lots of notice. You know.
Ditto what Ryan said.
Well, if I may suggest, if we have so much, you know, concurrence already around that time frame, and if Tuesdays do seem to work, may I suggest maybe offering Tuesday, April 19th or Tuesday, April 26th as potential dates for the next meeting, and maybe just make that decision here?
Vote for the 26th.
I second the vote for the 26th.
Okay. I believe, is there anyone who that wouldn't work for? It looks like we are unanimous in that being a good day. Why don't we move forward with that and save the doodle poll?
Okay.
So same
Well,
time
thank you
frame
all.
on April 26th.
Great. Thank you all for saving us this step.
10
That was
o'clock
too
again.
easy. That never happens. That's great.
Okay, is there any other business, anything else anyone needs to speak about? If not, I'd entertain a motion to end the meeting.
So moved.
Second. Is there a second?
Second.
Okay, all in favor of ending our meeting today at 11:12, say aye or raise your hand.
Aye.
Okay, any opposed or any dissent? It looks like we are ending early today with an extra 18 minutes in your day today. Thank you all
Thank
very
you.
much. Thank you.
Good to see you all.
Thank you.
Everybody.
Thank
Bye-bye.
you, everybody. Have a good day.